Right. Uh, Good evening to all of you. Welcome to this today's webinar, Clinical Assessment and Planning of Spastic Foot in Cerebral Palsy. And today's presenter is Dr. Pabitra Sahoo, sir. Sir is Assistant Professor at SVNIRTAR, Kolkata. Sir has published more than 50 publications. And I was just searching on the Google Scholar, more than 102 citations sir is having. As we all know, sir is conducting online webinars since last 2 years. More than 60 webinars sir has been conducted so far, and all of them are available on the YouTube on our official IAPMR channel. Uh, since last 2 years, I was behind the curtain. First time sir has requested me to moderate, so I'm on board. Sir, first of all, thank you from on behalf of all the PG students and all the physiatrists, and on the behalf of IAPMR also, that you are a very hardworking and good teacher, and you teach us like anything. So first of all, thank you. One more thing regarding today's topic. Cerebral palsy and spasticity. Most of the cases are spastic diplegia, where foot is the weight bearing joint, where the whole body weight is loaded on the foot, and this ambulation is one of the important aspect of rehabilitation. As we all know, foot is a complex joint where thus all three-dimensional dorsiflexion, plantar flexion, inversion, eversion, in fact supination and pronation, all these movements occurs at the foot, and multiple structures, agonist and antagonist, and specifically the spasticity lead to the various types of deformity. And as a physiatrist, we must know anatomy, biomechanics, in fact what spasticity, which spasticity is causing what type of deformity, and various interventions. This may be lead to this from orthotic, injection botulinum toxin A, or surgeries. So I hope Pabitra Sahoo sir shall cover all these topics, and this will be very useful topic for all of us. So thanks, Pabitra sir, and welcome, and over to you, sir. Thank you.
Thank you very much, Dr. Harshanand. So, as I said, today's talk is on this clinical assessment and treatment protocol for managing spastic foot. Let me share my slides with you people. Is it visible, my slides?
Yes, sir. Perfectly fine, sir.
Is it visible now?
You can make it full screen, sir.
This is full screen mode for me.
For us, sir, it's not showing, sir.
Okay, let me go back again. Is it okay?
Yes, now fine, sir. Perfectly fine, sir.
Yes, sir.
Is it full screen now?
Yes, sir.
Okay, thank you very much. So, as you all know that this after eradication of polio, the next common deformity we come across in our day-to-day practice for all physiatrists, that's cerebral palsy. So the management of cerebral palsy is still a dilemma. There is no concrete treatment protocol guidelines, fixed guidelines for management of different type of deformities or cerebral palsy as a whole. Still, the procedures are evolving. A lot of papers are coming. They started with muscle spasticity, then muscle fibrosis, then bone shortening. So gradually, this concept is gradually evolving. So there is no concrete treatment so far, established treatment. That's why the whatever paper published are or Delphi's methods rather than on a specific guidelines. So today, my discussion outline should be that's all about biomechanics of foot. As before going for any pathological foot, we must know what is the normal biomechanics and how it is disturbed in a case of paralytic foot or spastic foot, that is mechanism of foot deformities. And next part, I will go for clinical assessment of foot in spastic CP is just for the PG students when they get a case in examination, how do they assess a case of foot deformity as a short case in their examination. And the last part is the principle of treatment planning. So here, because of paucity of time, I will not go through all part of the treatment management. or a specific treatment, I will go with the overview of principle of management. You can adopt any principle, any procedure to that. I will say the indications when to do, what to do, but I will not go through the details of the procedure. This is about principle of treatment planning in spastic cerebral palsy. So most of my talk, I will not go through like buttocks injection or plaster cast, but yes, I will say that when buttocks is indicated, when plaster cast is indicated, but rest part I will go through how the muscle balance occurs by surgical means and other means to maintain stability of a joint to prevent deformities. That's my outlines of this today's presentation. So as you all know, food is a very useful thing for us. It provides platform for standing and walking, and it is a efficient support the body weight and that accommodates in different terrains, and that provides stability and balance for our locomotion purpose. So if you look to this foot, it's just a complex mechanism of function. It is not a simple way of walking like from heel to toe up. It works in a very complex way. If you look to this video, that during heel strike, it started with heel strike. That means in heel strike period, the foot must be supple, maximum supple enough to bear the ground reaction force to accommodate the uneven terrain. So foot must be supple enough during the heel strike period or during initial contact period. But during the toe period, like in this period, the foot has to be rigid enough to propel the body weight. So if that biomechanics is disturbed, I mean, during the heel strike, if foot is very much rigid, then there will be tremendous ground reaction force affecting the proximal joints. If the foot is not rigid enough during propulsion or during this toe up stage, that the foot is supple, then the foot cannot propel the body weight. So foot has to be supple enough, soft enough to bear body weight, to bear the ground reaction force during the heel strike, and it must be rigid enough to propel the whole body weight during the toe up stage. This is the basic biomechanism of a normal foot. Whenever this part is disturbed, that leads to gait abnormalities. So for this action, you must know about the biomechanics of the foot. That during initial contact, the heel must be everted. That means foot must go towards valgus. And for that is helped by the distal joint of the foot, which we ignore. We always look for the tibiotalar joint, that ankle joint. We look for subtalar joint. But there are other joints distally, like calcaneocuboid joint and talonavicular joint. They have a great role during locomotion for this typical mechanism of from valgus to varus, supple to rigid foot, right? In case of initial contact for a normal foot, heel must be everted. That means foot must be valgus. For that reason, the talonavicular and calcaneocuboid joint axis must be parallel. Okay, so then the foot will go to eversion and the valgus, and that's a supple foot, and that absorbs the ground reaction force. But just during the toe up stage, from mid stance to toe up stage, the heel has to be inverted. And how it is happen? It's by the divergence of the calcaneocuboid and talonavicular axis. If you look to this picture, during heel strike, the foot must be valgus, supple enough to ground reaction force to absorb the ground reaction force. And during the toe up stage, this calcaneocuboid joint and talonavicular joint must be divergent to keep the foot inverted and rigid enough so that the foot will help in propelling the body weight. This mechanism, whenever disturbed, that gives rise to a abnormal gait pattern, abnormal load bearing, and abnormal propulsion of the body weight. And this in spastic foot, this mechanism indirectly disturbed because of this difference of the spasticity on both agonist and antagonist group of muscles. So if you come to a spastic foot, see, suppose this is a normal foot, right? So we have tibiotalar joint, which works in plantar flexion and the dorsiflexion, and the axis is in the transverse plane. In this axis, the plantar flexion dorsiflexion occurs, and the muscle responsible are the dorsiflexor, that is tibialis anterior, extensor hallucis and extensor digitorum longus, and posteriorly the plantar flexor, that is the tibialis, the tendoachillis, and flexor hallucis, flexor digitorum longus. So these two agonist and antagonist, that is dorsiflexor and plantar flexor muscles, are balanced enough to carry out the function of the normal gait pattern in a normal person. But when there is a disturbance between flexor power or the extensor power, or one group is more spastic than other, that leads to a instability around the ankle joint. If you look to the subtalar joint is a frontal plane movement and the axis is a longitudinal axis, where the everters and inverters. Inverters is the tibialis posterior and everter is the peroneus brevis and peroneus longus. These two group of muscles work synchronized manner to maintain the stability of the subtalar joint, so that they work in such a way that the heel will be valgus in heel strike and heel will be varus in case of toe of stage, right? And if you see, these are all work in a phasic manner. That's how we decide that when to take a tibialis posterior, when to take a tibialis anterior for transfer, right? During heel strike, the tibialis anterior has to contract eccentrically so that the foot will gradually come to floor without a foot flap. So tibialis will work eccentrically there. It has to work, otherwise there will be a foot flap. So that occurs in case of the initial stage. During the toe up stage, the tibialis posterior has to work enough to make the foot inverted so that the foot will be rigid and the calcaneocubar talonoid axis will be divergent, foot will be rigid to propel the body weight. So just imagine when these muscles are either spastic or working not in a phasic manner. Like when the tibialis posterior should contract, that time tibialis anterior will contract. When the tibialis anterior should contract, that time tibialis posterior will be contract. If they will work they will not work in a phasic manner, then there occurs a biomechanical abnormality that leads to instability of the ankle and subtalar joint, that leads to gait deviation. And when that gait deviation persists for a long period without any treatment, without trying to stabilize those joints, that leads to establishment of deformity. That is the whole biomechanics of a establishment of a spastic foot deformity in different type of spastic conditions. Most common is the cerebral palsy. So coming to that, how this spasticity occurs, how it initiates. As I said, when there is a muscle imbalance, here the spastic muscles are not paralyzed. Muscles are there, they are spastic, but one group is more spastic than other. One has less voluntary function than other. So this imbalance occurs because of one group is over spastic than the other group. So that leads to instability of a joint. And when that instability persists, that produces a initial dynamic foot deformity. So dynamic foot deformity is the initial stage of deformity in case of spastic foot. That is evident by that the deformity will be correct by passive means. If the deformity will get during walking, if the child asks the child to walk, you will find the deformity. But if you try to correct deformity passively, it will correct perfectly. So that's a dynamic deformity, indicating that the deformity is still confined to the muscles because of its spasticity. And the deformity is still under our control by different methods of management, like buttocks injection, by splinting, by stretching, by sustained stretching, by casting. So all these methods of relieving spasticity or spasticity reduction measures are helpful till the deformity is in the dynamic state. Once the deformity goes beyond the dynamic stage or towards static deformity, probably we will fail to manage these foot conditions by our conservative or minimal intervention methods like buttocks injection or antispasticity drugs or splinting or by casting. So we always try to prevent the conversion of a dynamic deformity to static deformity. So early identification of spastic deformities are key to success of treatment of a deformity in spastic cerebral palsy. So when the dynamic deformity, static deformity, that means the deformity cannot be corrected by passive means. So there is an intermittent phase that's called mixed deformity, when you will have a combined some amount of dynamic deformity and some amount of static deformity. So these are mixed deformities. So how do you assess that? That mixed deformity, that is the most common use of TADUS methods of spasticity assessment, measuring a spasticity angle. I hope you all know what is a TADUS spasticity scale assessment. You always try to move the joint, try to correct the deformity, try to stretch the deformity with a first velocity, then second velocity, then slow velocity. So first velocity is with a slow velocity, and B2 velocity is at a gravitational velocity, and B3 is a voluntary velocity with a maximum velocity. So you first trace the deformity with a speed of either a gravity or with a voluntary deformity. The first catch you will get is the R1. Okay, then you gradually forcefully stress gradually. The one point will come when the deformity is not corrected further. That is the R2 stage. That comes to the static deformity. So this R1 to R2 is the dynamic period, dynamic deformity stage. Beyond R2 is the static stage. So if there is no R2, purely it is R1, it is completely dynamic. If it is R2 to our R1 is a maximum distance, maximum angle, then probably the maximum component is spasticity. If there is a less distance gap between R1 and R2, the angle is less, probably the whole deformity is static. Okay, so this is the concept, how you will decide that whether it is a dynamic deformity, it is a mixed deformity, or it is a static deformity. Now, coming to our clinical evaluation, how to evaluate a spastic foot deformity in CP, especially useful for the PG students. Examine a patient when the patient is approaching to you. Like all other conditions, you observe the foot pass. How to observe? If the patient is coming to the walking stage, observe the gait. If the patient is not able to walk, at least he can stand. Then see what is the posture of the foot during weight bearing position. You have to manage a weight bearing foot rather than a non-weight bearing foot. So you have to see what is the posture of the foot on the ground when the child is weight bearing. If the patient is not able to bear weight like GMF says 4 or 5 level, patient is confined to wheelchair, and you still want to correct the foot deformity. Sometimes you need to put the foot must be on the foot plate in the plantigrade position. If the deformity is there, then see the shape of the foot while the child is sitting on wheelchair. So in all the way in during gait, during standing posture, or if the patient not standing, see the shape of the foot while the child is sitting on the wheelchair. Then conventionally, you have to examine by inspection, palpation, movements, measurements, and special tests. This way also you can examine as other musculoskeletal conditions. Now, the coming to that gait part, as I said, one must see the gait of the child, how he's walking. Like, look to this side. This child is having I'm sorry. Yeah, this child is having a hemiplex type of gait with equinovarus gait. So you have to see that, examine that, what type of gait child is having. Yeah, this video is not working. Okay, so you have to see what type of gait, whether the child is walking with a equinovarus gait, with a hemiplegic gait, with a crouch gait, with a jump knee gait, what type of gait the child is adopting. You have to notice it with respect to foot and ankle. And the next part is how the limb is progressing, how the foot is progressing. Foot is progressing with the external rotation, foot is progressing with internal rotation. All these things will give a clue that even what is happening in the proximal part. Like a child is walking with a internal rotation gait. Limb is internal rotated during walking, right? So besides foot component, there may be associated adductor tightness, or there is associated medial most commonly medial hamstring spasticity can leads to a in-toeing gait or internal rotation gait of the foot. So This gives you a clue that there is a proximal abnormality, and these are the possible sites where you will expect a spasticity from. You will get it from the foot progression. And if the child with the external rotation gait, that indicates maybe it's at the hip level. There is excessive anteversion, and the femoral is rotated internally to counter it, to make the foot forward. The foot is rotating externally, right? So all these things you will get from the see from the gait of the child with respect to progression of the foot. Okay. Then next part is initial contact. Which part of the foot is coming in initial contact? Whether it is forefoot, whether it is midfoot, or whether it is a hind foot. If it is the normally foot initial contact should the heel strike, it should the heel. But actually heel strike is coming in contact or not first. So if the first initial contact is the forefoot, that means you are dealing with the equinus deformity, that is spasticity of the gastrosoleus. If the first contact is the calcaneus, that means the calcaneus is their initial contact for a long period. It may be because of the calcaneal foot where the plantar flexor power has poor. So you will get that information from that calcaneal foot. If the foot is coming with the initial contact, the mid-stand, the mid-foot is coming in contact. Maybe we are dealing with a crouch, dorsiflex foot, where the foot is directly contact with the mid-foot is directly contact with the ground at the initial contact. So initial contact you will give you an idea about what is the type of spasticity, what are the type of muscles weakness or overspastic in case of spastic foot. Then weight transfer, how he is transferring weight. A normal person, as I said, the foot has to be inverted and foot has to be rigid enough. The plantar arch should be exaggerated during the toe up stage for propulsion of the body weight. Whether that thing is happening or not. If that thing is not happening, what is happening? Maybe there is medial collapse medial arch. There may medial border is coming in contact. There may be valgus foot during the weight transfer mid stands to toe up stage. All this will give you a clue that where is the site of pathology. Then swing phase should not be ignored. That what is the status of the foot in swing phase? Whether there is a toe dragging, what for the toe dragging is there? Whether the foot is not going for dorsiflexion for which he is doing toe dragging, or there is incomplete knee flexion during the swing phase for which the toe is coming in contact because of apparent lengthening. Knee is in extended position in the mid swing phase. The knee is supposed to be flexed for ground clearance. If the knees remain extended, then the foot will come in contact with the ground, toe dragging will be there. So toe dragging in swing phase also give you clue whether the deformity is at the foot and ankle or deformity at the knee, what is the action of the quadricep, what is the action of the hamstrings. All these things you will get clue from the foot position. And next part is arm swing. Should not be ignored. Sometimes in case of mild deformity, mild CP, where spasticity is not clear, sometimes quickly you can see that what is the relation of the arm swing along with the foot progression. If the arm swing sometimes show some clue, will give you a clue that yes, you are dealing with a spastic condition. So arm swing also one must notice. So these foot and ankle problems can be the primary cause of the gait abnormality, or the secondary problems at the higher level can affect the foot and ankle, giving rise to a deformity at foot and ankle. That must be also evaluated. Okay, so coming to our conventional way of examination, clinical examination in all musculoskeletal conditions like other conditions, here also you can examine in that way. Start with your inspection. So gait phase is over. Then next part is the inspection. From the inspection point, look to the foot. What abnormality you are getting the foot? Is there any callosities? Where is the callosities? Is it in the medial border? Callosities means hypertrophied thick skin. Whether you find it in the medial border, whether you find it in the lateral border. If the medial border callosity is there, that indicates you are dealing with a flat foot. Maybe you are going to deal with a crouch, right? If you are finding the callosity in the lateral border, that indicates that maybe you are dealing with a cavovarus foot or a varus foot. That's you can see that maybe tibialis posterior spastic here. And sometimes you get callosity in the dorsum of the great toes. That's a telltale sign that you are dealing with a spastic foot. During walking, the patient child will toe drag and you will get callosities on metatarsophalangeal of the great toe, second toe, or third toe. Okay. Then bursting, of course, is not marked in case of spasticity. Other lower motor conditions, you will get bursting in paralytic foot cases. As I said, medial arch must be evaluated. Too many toe signs is a sign to see whether you are dealing with a collapsed arch, collapsed medial arch. If you look from the back, you will see more than two toes. A normal person will hardly will see two toes from the back, from two lateral toes. But like in this picture, so if you see from the back, you will see almost up to second toe. That's a too many toe sign, indication of a valgoid foot. Then what is the extent of forefoot abduction? Forefoot abduction indicates that there is external tibial torsion, foot is abducted. Then when you plan for any orthotic management for stabilizing foot and ankle, that must be taken care of. This abduction is occurring at the metatarsal joint. This abduction is occurring at the subtalar joint with eversion of the foot. So forefoot abduction also one should look for, because in adult cases of CP, when you fail to manage the foot and ankle by foot and ankle orthosis, that time the surgical intervention is required, where we go for lengthening of the lateral border of the foot. So this is the important clue point. How you are proceeding to manage length of the medial border and lateral border is important. Broadening of the heel. Broadening of the heel is a telltale sign of the weakness of the plantar flexors. The plantar flexors are very important for propulsion of the body weight. So if there is a broadening of the heel, that indicates that the plantar flexors are weak. Might be iatrogenic, might be excessive stretching, might be excessive stretching by plaster casting. So that mostly it is iatrogenic in nature. Or as the child grows also, the dorsiflexors became overpower, and that leads to the crouch posture, over dorsiflex foot. Besides that, any other visible deformities like valgus, hallus valgus, or any callosities, bunions, these things you can mark in your inspection findings. Then coming to palpation, you have to confirm all your inspector findings by palpating it. You have to look for any bony tenderness anywhere, any tenderness over callosity, indicating that maybe you are dealing with the infected callosities. So that has to be dealt with. Then bony landmarks, prominence of the lateral malleus, prominent of the talar head, prominent of the talar head laterally or prominent talar head medially. Talar head prominent medially indicates that there is a collapsed talonavicular joint. So you have to advise your orthotic treatment accordingly, supporting your talonavicular joint. If the talar head is palpated laterally, that means you are dealing with a varus foot. So accordingly, you have to deal with your orthosis also. Then tender callosity, as I said, when the child walk for a long period, over and over that callosities get infected and producing painful infection. So to avoid that, we have to correct the deformity. We have to do the correct footwear modification or orthotic modification, so that the callosity pressure over the callosity can be avoided. Next part is range of movement. That's really important, because this gives you a clue that what procedure you are going to do. So mostly we are dealing with range of movement as far as the foot and ankle is concerned: ankle joint, subtalar joint, metatarsophalangeal joints. So you will expect some amount of limitation of range of motion in different joints. So why this limitation is possible in case of spastic foot and ankle? It's because of intrinsic contracture of the joint, or by contracture of the spastic muscles crossing that joint. So initially start with a spasticity of the muscles. When the spasticity remain for a long period untreated, that give rise to static contracture of the structures around the. What are those structures? Static contracture of the capsule, static contracture of the ligaments. All these things leads to a static deformity. So these static and dynamic component both will lead to limitation of range of motion. So coming to different joints, that how do we evaluate this range of motion? We all know for a normal ankle joint, we have 20° of dorsiflexion, around 60° of plantar flexion. So here you have to see how much of dorsiflexion is coming, how much of plantar flexion is coming. So if you are dealing with mostly you are dealing with a equinus deformity where the dorsiflexion is limited. Okay, because of spasticity of the gastrosoleus, most common deformity in cerebral palsy, spasticity of the gastrosoleus. So that has to be evaluated because the treatment different in the different conditions, whether the deformity is because of spasticity of the gastrocnemius, spasticity of the soleus, spasticity of the both the muscles combined together, that will decide what treatment we are going to do. So you all know the simple test is the silver scale test. If you in extended position of the knee, you try to dorsiflex, see how much amount of dorsiflexion you are achieving, and in plant do the knee go for knee flexion, then try to dorsiflex the foot and ankle and see how much of dorsiflexion is improving. If both knee flexion and knee extension, the deformity or plantar flexion angle is same, that means it is a mixed contracture or a contracture of soleus only. Okay. If the deformity is getting corrected, then soleus can be excluded. That means the gastrosoleus is bijoint muscle. When it is knees flexed, the gastrosoleus is relaxed. So you will gain some amount of dorsiflexion movement. That decides you that what type of treatment you are going to do. So if the soleus is intact and the gastrosoleus is spastic, then you have to go for fractional lengthening gastrosoleus at zone 2 level. If there is a mixed contracture, you can go to a zone 3 level. But if you are dealing with a hemiplegic spastic equinus deformity or equinovarus deformity, there one limb is normal, only one limb is pathological. You can go for in zone 4, that is lengthening of the tendo-Achilles by jet plastic. As far as your the dynamic deformity is concerned, by management by botulinum toxin, or management by stretching or casting, so long as the gastrocnemius is involved, you can inject in the gastrocnemius. When you find the soleus is the pathological, then you can inject the soleus. So you have to decide which muscle is spastic by silver scale test. Then you can treat the muscle accordingly. Subtalar joint, that's most ignored, that's less visible, less we hardly give any importance to the subtalar joint. But believe me, this is the more difficult joint to manage, and really this is the root cause of all these deformities. The equinus deformity is very easy to correct, but subtalar deformity is very difficult to correct. Okay, even by surgical means or by orthotic means. Okay, so because we are dependent on orthotics people, the orthocist or the prosthetist for preparing this orthosis, how properly they take mold, how properly they take cast, how properly they well filled with the orthosis, whether you deal with a SMO or you deal with a UCBL. So how well they have fitting, how they are maintaining the heel position or calcaneus position at a subtalar joint, that decides that how you can stabilize your joint. And really, it is a very tough decision. Although we plan, but the treatment or the management part, we depend on other people. That's the problem with us. But similarly, for surgical also, there is not a single surgery which can confirm the stability of a subtalar joint. If you do one way stabilization, it will affect in other way. As you know that this subtalar joint, calcaneocuboid, or talonavicular joint, all the three joints work in a congruent manner. So you fuse the subtalar joint, that other two joints will work in different way. So they start developing osteoarthritis at those levels. So really it is a tough condition to decide, but you must see that the subtalar joint is not big. If you have opportunity to examine the child in the early stage, please look for the subtalar mobility, how it is moving. If it is really mobile, yes, you are fortunate enough, you can stabilize the joint with the orthosis. Once a fixed deformity develops at the subtalar joint, it's really very difficult to stabilize the subtalar joint. However, you must know how to assess a subtalar joint. I hope students must be knowing about subtalar joint. This the primary movement is eversion and inversion. That is assessed by goniometer, asking the patient to sleep in prone position over a couch and hanging the foot at the side of the couch. Draw a axis joining line joining the tip of the medial malleus to tip of the lateral malleus. You have to find the midpoint, that is your fulcrum, and the static limb is along the mid course of the tendinoachilles, and the dynamic limb of your goniometer should be from the fulcrum to the calcaneal tuberosity. Then you try to do eversion and inversion of the holding the calcaneum very snugly, try to evert and invert, and accordingly you can measure the subtalar joint motion. So that is possible in case of open kinetic chain motion of the subtalar joint. But the most of the movements, most of the pathology occurs in the closed kinetic, when the child is bearing weight. That time, the closed kinetic chain motion, that is difficult to assess by goniometry. Yes, there are other methods of assessment of the subtalar joint motions in closed kinetic chain way, that is using inclinometer, that gives about the eversion or inversion of the calcaneus position. That gives you about the subtalar joint. And another indirect way of method of assessing subtalar joint motion is by assessing the height of navicular tuberosity from the floor. This is a paper which is published about the Journal of Sports Physiotherapy. So they have described about how to assess a subtalar joint motion in closed kinetic, that is in the weight bearing position. So my point of emphasizing here is that the subtalar joint should not be remain ignored. It should be evaluated in the early stage till it is in a dynamic deformity stage. So this is all about the different joints, even important joints. I am not going to the metatarsal joints or the tarsometatarsal joint, very lengthy procedure. However, metatarsal joints, they involve, in case of crouch posture, in planovalgoid foot, when the foot is ineffective for propulsing body weight. The gastrosoleus is contracting, but foot is not rigid enough to propel the body weight. So in the force of the gastrosoleus, there occurs a break at the mid-tarsal joint level. It may be at the talonavicular joint level, and the break occurs that area. The forefoot became everted out, valgus out, and the hind foot remain in valgus stage. So that's about the distal part of the joint. Now coming to different deformities we expect in case of cerebral palsy. The most commonest deformity in cerebral palsy is equinus foot. We all encounter this deformity in different types of equinus foot. If you are fortunate enough, you are dealing with a hemiplegic equinus, yes, you can correct it 100%. But if you are dealing with a diplegic equinus, then maybe you have to think so many times for assessing the foot deformity. Okay, so this part will touch only the clinical different deformities, and different during planning we'll have a separate section. So equinus foot, it's, you all know, it's because of the spasticity of the plantar flexors. So long as the spasticity is dynamic in nature, you can correct it. So if not corrected, then that leads to a static plantar flexion. And when static plantar flexion continue, the child may present with a genu recurvatum, or when the plantar flexion is there, there will be relative lengthening of the foot. To compensate that, knee will go to flexion. So knee will behave in both the way. If the metatarsal phalangeal joint child is walking, maybe it will go to flexion. If at the hind foot, it is forefoot is there, the initial contact, the foot will go to hyperextension. This decided by where your ground reaction force is coming. If your ground reaction force is because of equinus, it is going anterior to the knee joint, it will go to recurvatum. If it is going behind the knee joint, then it may go to flexion. And flexion of the knee because of equinus is because of the relative lengthening of the foot. And other way also, there is the other problems that there will be inefficient propulsion. How it occurs? For a normal propulsion, the muscle has to work in full range, right? Then you will get a maximum power. When a muscle get a chance to excurse in a full range, you will get a maximum power of excursion. But when you have a limited range of motion to muscle to work, then the power generated will be less. Exactly this, the same thing happen in case of equinus foot. What will happen? The foot is already in plantar flex position. So there is less movement there. There is less movement to muscle to excurse its power. So there will be inefficient gait in case of equinus foot. So if the equinus foot is not treated in case of diplegic, that goes beyond certain series of events. As the age are nowadays, because of the increased rehabilitation management in cerebral palsy, the longevity, the lifespan of the cerebral palsy children are increasing. We are getting CP children of 1 year, 2 year age to 25, 30 years age group. So earlier, those 25, 30 years, the survival rate for CP child were less. Now, because of our effort, our physiatrist group or rehabilitation effort, the lifespan is now increased. So as the age advances, the muscle spasticity increases, muscle shortens, but the bone will grow on its own way. So there will be a relative shortening of the muscles, and that leads to static contraction. And that time, the propulsion of the body weight will be poor, and the series of foot changes occurs from a equinus foot to valgus foot, then midfoot break, talar head will be go down and prominent on the medial side, but the calcaneum remains still in equinus position. This is the wonder in this case, that the foot appears plantigrade, but if you take a plantigrade foot X-ray from the lateral view, you see that calcaneus position is not in neutral to the axis of the tibia. It will still remain in valgus position, in equinus position. So that is typical way how to check it. You invert the foot, lock the subtalar joint so that the foot will not go to valgus, then dorsiflex it. That time you will find out the true equinus deformity there. So many times you do mistake, students do mistake when the examiner asks, see the dorsiflexion, what is the range of dorsiflexion? Straightway the examiner or the student dorsiflex the foot. No, that is not happening in case of spastic CP. Okay, so if the child is having a flat foot or a valgard foot, make it 10 degree of inversion. Try to lock the subtalar joint, bringing back to little bit inversion. Then dorsiflex it. So once you lock the subtalar joint, the calcaneocuboid axis and the talonavicular axis, they become divergent. They will not break. Okay, as I said, these three joints work together. So if you dorsiflex it, then you will get the true equinus. So this is a very fundamental error done by the students during assessing the dorsiflexion. There is a condition called apparent equinus. Look to this picture. This picture shows that foot is in equinus position, but this is the axis of the calcaneus and this is the axis of the tibia, and it is 90 degree. So this is not a true equinus. This apparent equinus is because of proximal knee flexion deformity, and this is compensated by equinus position of the foot and ankle. Okay, so if you're just examining, just looking to the gait of the child, don't say that this is a equinus foot. No, you examine the foot in supine position also. Look to the proximal joint. Then you can say that whether it is a true equinus or it is a apparent equinus. The next commonest deformity is the equinovarus deformity. And this is the commonest deformity in case of hemiplegic. Hardly seen in case of diplegic, but yes, as I said, CP progression, you never know in what way it will go. Classical teaching says that it will start with a dynamic equinus, then fixed equinus, then jump knee gait, then crouch gait. This series of events occurs in evolution of foot and ankle in case of CP, spastic foot. But that is not always true. Even many cases we are getting diplegic. One side is a valgoid foot, other side is equinovarus foot. This combination we can get also. However, in case of hemiplegic type of CP, most of the times, 99% of time, you'll get a equinovarus foot. And look in that situation, don't be hurry enough to go for straightway for managing that. Examine the muscle. As I said, all these deformities are because of imbalance of the spasticity. One group is spastic than other group. So check the power of the inverters and inverters. Look for the gastrocnemius tightness, whether it's soleus or gastrocnemius tightness is there, whether dynamic or static deformity. Accordingly, choose your botulinum toxin, plaster cast, or surgery. If surgery were to be done, zone 2, zone 3, zone 4, depending upon which muscle. So it always depends upon your assessment, deciding that which muscle is the culprit one here. Then look that in these cases, in varus foot, they in long run, they start with the equinus starting on the tip of the head of the metatarsal like this, but in long run, they walk on the lateral border of the foot. And when they walk for a prolonged period, they develop bursa on the lateral border of foot. Okay, so in this case, you have to judiciously evaluate that with how to go ahead with injection, casting, or surgery. If surgery, which level? Next is pes valgus. Most difficult deformity, spastic deformity to handle by orthotic means, by surgical means, whatever it may be. Okay. Unfortunately, 25% in diplegic CP and quadriplegic CP, they have this pes valgus deformity or plano valgus deformity. 68% spastic quadriplegic patient, they ultimately land with a valgoid foot and ankle. Okay. And as the age advances, I said, there will be collapse at the talonavicular joint. Mid-foot break will be there. They ultimately land with a this valgoid foot. And when they walk with the deformed foot, the callosities develop on the medial border here, the head of the talus. Here is the head of the talus. The patient will develop callosity over these areas. Okay. And again, when they start like the walk like this, there will be foot abduction. The foot will be abducted outside, and the time will come when the patient will walk on the medial border on the head of the metatarsophalangeal on the medial side. So all big amount of bunions, callosities will develop that side. So these cases must be evaluated properly to see whether the peroneal is very much spastic or tibialis posterior is very much weak. Okay. And third component is the gastrosoleus. Once the valgus started, the heel will be inverted out. So this gastrosoleus will work in a vicious cycle, right? So when the heel little bit out, lateral to from the midline, the gastrosoleus will work on the lateral side now. There will be when there will be contact, there will be further valgus. So this vicious cycle will go on. So that has to be stopped by bringing back the this gastrocnemius function to the midline by SMO or by UCBL in case of dynamic foot. So another one is also EMG study is required in this type of patient to see what is the status of tibialis posterior, what is the status of peroneal. Is it really the peroneal are hyperphagic, hyperspastic, or the tibialis posterior is weak enough to maintain the talonavicular joint or the medial arch as it work like a sling. So by doing EMG also, we can see the culprit and accordingly we can plan our treatment. If the there is a peroneal spasticity is there, then that can be taken up. That will discuss during the treatment planning. Equinovalgus, as I said, equinus is a secondary component of the valgus. As I said, when the foot is go to valgus, that the insertion of the tibial the tendon is shifted laterally. And when for the propulsion, the body it will contract, it will further shift the calcaneus laterally, and the heel remain in the equinus position. So the person will walk initial contact as a midfoot. Okay, so this happens started the equinus foot. There will be a calcaneal eversion that exaggerates the deformity. Once the calcaneus is everted, then this talonavicular axis and calcaneal axis became parallel. That make the foot complete supple, and there will be metatarsal break. Okay, as I said earlier, please go for check and whether it's a true equinus or not. Don't straightway see that foot is plantigrade, there is no equinus deformity. Maintain the hind foot before examination. Maintain the hind foot varus, little bit varus, then foot is supination, then dorsiflex. You will get the true equinus deformity. Ankle valgus in the very late stage, when first medial arch collapse, then subtalar valgus, mid-foot break, then third is the ankle valgus. Please don't forget to take X-ray because ankle valgus confuses with the subtalar valgus, subtalar joint valgus. You have to differentiate between these two. Okay, so how do you see that ankle valgus is difficult to see by clinical means because the joints are so limited space, ankle joint and the subtalar joint, the space is hardly 2 centimeters. So very difficult to elicit that where is the site of valgus. Of course, the main site is the subtalar joint because of the commonest site of inversion, eversion, subtalar joint. But still, ankle can go to valgus and you will confirm it by doing a weight bearing X-ray. You put weight bearing X-ray when the distal tibial physis is the same level of the lateral malleus physis. That is the indication of ankle valgus. What is a normal ankle joint? This lateral malleus physis must be lower level than the distal tibial physis. So this is a clinical indicator, a radiological indicator that this patient is also having ankle valgus. So you have to go to SMO, not UCBL. You have to go for SMO, supramallar orthosis. That will some extent control your ankle joint. Or else, if the deformity is static, it's not correctable. So orthosis is not be helpful. That time you can go for growth modulation, right? So I don't want to go into detail, but you must know that when should go for a SMO, when to go for a UCBL, and when to go for a medial arch support only. Hallux valgus is always secondary to the planovalgus foot. As the patient started bearing on the medial border of the foot, the grade 2 deviates laterally. So always patient have a lateral thrust during walking. These are very energy consuming gait, this crouch gait. They always bear on the middle border of the foot. As I said, this is not advantageous position. The foot has to be inverted for the propulsion body weight. Unfortunately, the foot remain in a valgus position. Body try to make the full effort for propulsing the body weight or lifting the body weight. Not possible. So that almost that all weight is borne by the middle border, that to more towards the distal side, because heel is in equinus position. So the most weight is borne in the distal part. The heel goes, the grade 2 goes to valgus position. Calcaneus deformity is not so common. This is mostly sometimes iatrogenic. How iatrogenic? That you have not examined the foot. Patient came with a equinus, might be was in upper and equinus. You thought it is a equinus because you saw the child gait is walking the equinus foot, and you straight away go for TL lengthening. Okay, the grievous mistake you have done now. Okay. Second thing, patient coming with a valgus deformity or a simple other equinus dependent where the soleus is not the factor. It's a gastrocnemius which can be managed by buttocks or plastocasting. You went for TL lengthening in zone 4. So gastrocnemius would big. That would give rise to a calcaneus deformity. The dorsiflexor over spastic, you have over lengthened the tendo Achilles. So better to keep some amount of equinus rather than going for TL lengthening. This is the fundamental principle in managing a equinus. Don't try to go for dorsiflexion while correcting a equinus deformity. Okay, otherwise you will land with a calcaneus deformity or with a Krauss posture. Bunions, these are all adaptive deformities. Bunions, like here, you can see it here, bunions occurring here. These are all secondary changes occurs when the person continue to walk with lateral medial border of foot. So there, I must say some little bit some basic special tests, because the last part of exam is a special test. So one confusion test is when you are not sure whether your dorsiflexors are working or not. If child is very young enough to respond to your command, to understand your command, child is having a mental retardation, MR, you don't know whether the dorsiflexors are working or not. You are not able to decide how to go ahead with this deformity. So that's a confusion test. If the child can do hip flexion against resistance, you resist it, ask the patient to lift his thigh. So there will be involuntary dorsal contraction of the dorsiflexors. That's a confusion test, to simple way for the small kids to see whether the dorsiflexors are working or not. Silver scale test already we have discussed. I don't want to discuss anymore here. Tiptoe sign also. This is a simple test to see about the status of the tibialis posterior. Of course, this needs that the child must be a GMFS 2 where the patient can stand on the tip of the toes. Then we can see whether the tibialis posterior is working or not. Then you have to decide that whether you take the tibialis posterior or tibialis anterior for transport. So this is all about how you clinically evaluate a foot. Then next part is the treatment planning. How to plan your treatment. So these few slides are very important before planning of treatment. When you approach a spastic foot, see what are the muscles that are paralyzed or weak than the opposite group of muscles. Okay, if some muscle is there, what is the power of each muscle that are functioning? Okay, Third, is there muscle imbalance that ankle, subtalar, or mid-tarsal joint that has either already produced a deformity or has a potential to produce a deformity in future? You expect that peroneas are very spastic or tibialis posterior weak. You will expect that yes, this foot is going to valgus, this foot there will be a mid-tarsal break. So you have to address the situation in the early stage. And the last one is, are there any muscle grade 5 power, well control, well voluntary control power that can be spared for tendon transfer without producing a fresh imbalance? Again, this point to be noted. If somebody is having a one group of muscle having good voluntary power, you say, I'm happy, this muscle is there, I can play with this muscle. But see, if you are taking that muscle, is there a is the child is going to second deformity? That is possible in case of lower motor type of disorder, like a polio, like a spina bifida. But in case of spastic deformities, be sure other group of muscles are not paralyzed. These are least spastic. So if you take the muscle which is important, then least spastic muscle became hyperactive. That will produce a reverse deformity. So this point should be also taken care of. Then, most important point, when you plan for any surgical correction, is there any fixed contracture? Then that means it's a static deformity. Your strategy will be changed. So before planning for any buttocks or casting or surgery, see whether there is any fixed contracture there or not. Is there any bony deformity? Adaptive deformities in the bone. Child started walking for a long period with equinovarus deformity. The cuboidal or trapezoidal shape. The talar head will be flat. The talar head will be out. So out of talonavicular joint. So it will not grow properly. So see, is there any bony deformity? If the bony deformity is there, then tendon transfer is not going to help you. Or your spastic, antispastic will not going to help you. Stability of the proximal joint. You are treating the distal joint, valgus, what is the knee flexion difference still there? So take care of that part also. If surgery it is fine, or else by orthotic means stabilize the proximal joint and look for the proximal joint, not concentrating only to the foot and ankle. Then also stability of the opposite side. Why I said hemiplegic, they will have good outcome, but diplegic, they have poor outcome. So because the opposite side is weaker as well. So one should see the opposite side of the joints also. What is the status of the foot and ankle in the opposite side? Now, the coming to treatment planning proper. So, what are the principles of the treatment planning in case of spastic foot? Restoration of the biomechanical abnormalities. The principle, heel valgus, then heel varus. Foot pronation, then foot supination. This mechanism should go on repeated in each stride. Ensure that ankle and subtalar joints are stable throughout the stance phase. That's the phase where the whole weight is borne by this ankle and subtalar joint. Facilitate powerful push-up at terminal part of the stance. As I said, foot has to be inverted, rigid enough for the propulsion of the body weight. So, valgus foot cannot propel the body weight. Restore active dorsiflexion during swing phase of the gait. So, whether the foot is going to neutral position or dorsiflexion or not, restore that. Ultimately, we are aimed towards a painless, plantigrade, functionally stable, and weight-bearing foot. That is our motto. Whether managed by antispastic, managed by orthosis, managed by surgery. So now coming to correction of the deformities. So as I said, we have two groups of deformities in CP: dynamic deformities and static deformity. In dynamic deformity, can be corrected by weakening the deforming force. One group is overspastic. Reduce the spasticity that side. Try to bring to a power equal to the opposite group of muscles, which are less spastic. So what are the ways? How can you do that? You can go antispastic drugs, injections, reduce the spasticity on that side, or by surgical means, by tenotomy, or by tendon lengthening, all either tenotomy or tendon lengthening or transfer. That will reduce the weakens the power by 1 or 2. Great. So that's also a way to reducing the spasticity. Redirecting the deforming force into a corrective force by tendon transfer. Like in case of calcaneus foot, peroneus can be transferred to the heel. Just change the direction of the course of the peroneus. Don't cut, don't transfer. Just change the direction of the course of the peroneus longus. That will work like a plantar flexion. So That way also it is possible. But for static deformity, there is no ways. We can, yes, there are other ways, like some ways of conservative management are there. Like nowadays, we are in our institute, we are doing wedge casting. Wedge. By doing multiple wedge casting, you can correct some amount of fixed deformities. So long as the bony deformity is not. If the deformity is confined to the capsules, ligaments, and some extent to the muscles, that can be corrected also by conservative means by doing serial wedging, serial wedge casting. You can correct it. Or else release or lengthening of the tendons, ligaments, capsules, the maintenance of correction by tendon transfer or arthrodesis. If the bony deformity is established, have to go for osteotomy or arthrodesis. Now, how to judge, how to decide when to do what type of procedure? Okay, so start with the static deformity, because dynamic deformity first preference of conservative. Antispastic, casting, splinting, wedging, all these things will be in the dynamic deformity. But in the static deformity form, what is our limitations? That we must know. Okay, so if you have a muscle of power 5, that means you have a good muscle power in one group of muscle, other groups are weak, provided you have the transfer tendon will not produce any fresh instability. As I said, patient have a valgus varus deformity, so that means the tibial is posted to spastic. You will take the tibial is posted to the lateral side to correct the varus deformity or inversion deformity. But that will land with another deformity, valgus deformity, which is very difficult to correct. Okay, so you should choose a muscle that it should not create a fresh deformity, right? And the third principle is that there should not be any fixed deformity. Then only we can go for tendon transfer and stabilize the joint. Okay, if the second part, if the second is not suitable, that means the tendon transfer will create another deformity. The second point is not valid here, right? Fixed deformity of the ankle or subtalar joint. Okay, sorry, there is a third one. If the fixed deformity is there, then you have to correct the deformity first, then go for tendon transfer. If the third point is not valid, if the second point is not valid, that means taking out the tendon to create another deformity, then transfer tendon produce a fresh deformity. That time, first stabilize the joint which is about to deform by taking out the muscle, then transfer it. Okay, like in case of if you want to transfer, you have to transfer tibialis posterior, then you stabilize subtalar joint by fusion, then transfer it. Okay, so this is how you decide. First three conditions there. If one is not there, what to do? When two is not, then what to do? Now, coming to the dynamic deformities, which are focus of management. The principle here is that if the tendon transfer is possible and likely to restore the muscle balance, simple transferring the muscle, the other side will help in correcting the deformity. Go for tendon transfer. Ultimate aim is stabilize the joint by maintaining a balance between the agonist and antagonist group of muscle. But situations where tendon transfer is not feasible, or you don't know tendon transfer, what to do? Then check the muscle power. What is the agonist power? What is the antagonist power? If the difference is very less, almost both have same deformity, but one group is a little bit overpowered than other, then that time go for lengthening of the tendon. How it will be beneficial? If you lengthen it, as I said, the power will decrease by 1 or 2 grade. Now the power will be equal on either side. You will not have any instability. Third group, where here also tendon transfer not possible, but the difference of power is gross. One side is very severely spastic, other side is less spastic. There is a gross difference of the voluntary control of power between these two group of muscles. That time you can go for tendon tenotomy, okay, or tenotomy of the strong muscle. So indication of the lengthening, indication of the tenotomy. If the deformity is very severe, tendon transfer not possible, go for tenotomy. If deformity is less severe, tendon transfer not possible, or you don't have facility of tendon transfer, go for tendon lengthening. This is the basic way how to maintain a balance between agonist and antagonist to prevent deformity. So coming to just schematic way of, we are running short of time. Within 10 minutes, 5 minutes, we'll complete it. So this is just a schematic way of presentation. Like in the case of equinus deformity, see in equinus, these dorsiflexors are weak, the plantar flexors are strong. So what to do? You have to take one muscle to one powerful muscle. Here the evoter inverters are normal or equally spastic. There is no imbalance. So now you can take 50% of the tibialis posterior anteriorly. Split transfer of the tibialis posterior, which augments the dorsiflexion power so that the equinus deformity can be prevented. You can take the whole tibialis posterior if the power is very minimum in the dorsiflexus, provided child is having a hemiplegic type of cerebral palsy. Diplegic, don't take the whole tibialis posterior. You can take a part of the tibialis posterior. Okay. So other options there also. One can take peroneal also. That means these inverters can be taken as a dorsiflexor. This is simple way principle of correcting a equinus deformity. Next part is equinovarus deformity. So what foot is in varus position means there will be overspasticity of the tibialis posterior and a weakness of the peroneus, longus and brevis. At the same time, because of equinus, because the dorsiflexors are weak. So equinovarus, dorsiflexors and everters are weak. We have muscle of inversion that we can take to the dorsal power. So it helps in dorsiflexion. You have taken out the spastic inverter so that the varus deformity can be corrected and dorsiflexion can be augmented. So this is about equinovarus foot. Next is equinovalgus foot. Very difficult condition to correct this one. So most of the times we prefer to go for orthotic management, or we can go for subtalar fusion to stabilize the subtalar joint. However, theoretical options are there where the peroneal can be transferred to the dorsum. So everter power you will take out to prevent valgus deformity, peroneal spasticity. Also it augments the dorsiflexor power. Okay. Calcaneovalgus deformity, most of the time it is iatrogenic, as I said. With the overemphasis, you have lengthened the tendon Achilles, landed with this. Very difficult to correct here in this case. However, there are methods described. Tibialis anterior, since it's overpower, dorsiflexor overpower, tibialis anterior can be transferred to the calcaneus or to the tendon Achilles, so that we will gain power of the plantar flexor. As I said, plantar flexor is more important than dorsiflexors. Dorsiflexors can be managed by orthosis very well, but plantar flexor weakness is very difficult to manage. Okay, and other way, peroneus longus can be transferred. As I said, the root can be rerouted. The peroneus longus can be rerouted through the calcaneal tuberosity, where instead of everter, it will work like a plantar flexor. When the deformity is very much severe, you have least option with you what to do. Nothing can be done. So that means there is a gross instability between dorsiflexors, plantar flexors, inverters, everters. Look that if the deformity is flexible, straightway go for bracing. The best way, go for bracing, casting, and spasticity reduction procedures. And sometimes when the deformity is very fixed, severe, you have no option. You have to send the person for a pantalar fusion for stabilizing the subtalar joint, stabilizing the ankle joint. That's for the grossly deformed foot. This is all about my presentation. My take-home message is that foot and ankle deformed treatment in CP is a double-edged sword. You must evaluate the foot and ankle very correctly. Proper clinical evaluation and precise decision making is the key to success. If you are not sure, go for orthotic management rather than going for any surgical harm. So you have treating plan for treating one deformity, you will present with the other deformity, which is further difficult to treat it. So we may not help a person, but we should not harm a child. That is my take-home message. Thank you all, and I welcome you all to our coming surgical workshop. As you all know, every year we used to have one surgical workshop for our friends who are interested for rehabilitation surgery. This time we are going to have in 23rd to 26th of July. If those friends who are interested, please contact us so that we'll have necessary arrangement. Thank you. Over to Harshanand, Dr. Harshanand.
Thank you, sir. Thank you, Pabitra sir. It was a very nice lecture. We have covered almost everything in detail. This includes from various etiologies of the foot deformities and the basic biomechanics. This will be very much useful for the PGs to understand how the foot biomechanic works. Then you have explained in detail about this detailed assessment and clinical examination, as well as this categorization of the foot deformity, specifically static and dynamic, is very useful for the physiatrist to plan the intervention. And as you mentioned the take-home message, putting a knife is a double-edged sword, as you rightly correctly said, sir. And this will help the RPGs or other colleague physiatrists to plan the intervention accordingly. So I invite the questions from the audience. We have received more than 85 audience today, sir. This is a very good number. So I request audience to put your type your questions.
Before any questions in the chat box, Harshanand, if you have any also point to discuss here, anything left in this presentation or anything you want to add to this presentation, you can tell.
Actually, sir, the foot intervention, I believe that in 1 hour or 1 hour 30 minutes not possible to explain. The foot itself, in fact, the biomechanics, it will take 2 to 3 hours to explain in detail. And once you get to know the complexity of the biomechanics, then it will be very easy to identify the pathologies, describe the deformities, and put the intervention. The key of this lock of the CP foot is the biomechanics, sir. And as you have almost 40 minutes you have spoken about this biomechanics and various foot deformities. This will be very much it was very good, sir. Regarding the intervention, sir, as you also know, sir, because of paucity of time, we couldn't a little bit stretch a bit. I request you, sir, you can have another class on this exclusively for the intervention in the same series, where various types of tendon lengthening, tendon transfer, just like tibialis posterior transfer, how exactly you do, or you can have a simple video recording of the same 5 minutes or 10 minutes. So this will encourage the PGs how exactly it happens, because most of the PGs they read on the textbook. Yes, tibialis posterior ko transfer karna hai, midfoot pe lena hai, or other muscle transfers are there, or sometimes orthodesis are there, especially where there's a complex foot deformity is there, where there are no other option than the subtalar fusion or other ankle joint fusion. So I would request you, sir, if you get time to have small clips of the videos exclusively for the surgical interventions of the foot, especially in the CP.
Okay.
That's my suggestion from my side, sir.
We'll take care of that. So let's see what are the questions. Please go through the questions in chat box.
Yes, sir. Nageshwar has asked one common association is that hallux valgus. So please guide about it, how to correct or how to manage the hallux valgus in CP.
See, you have to check it whether the deformity again is whether it's static or dynamic. But a dynamic deformity, maybe it is because the child is walking in the medial border of the foot and he has always a medial thrust of the foot instead of metatarsal joint or the hand, the forefoot for propulsor. He is using his great toe medial border for propulsion of the body weight. So all the weight is the weight bearing force is borne by the medial border. So each time he's walking with the medial border of the foot, the great toe is forced towards the lateral side, right? So that will give rise to a hallux valgus. So long as it is a dynamic deformity, we can manage by elevating relieving the weight bearing the medial border, by elevating the medial arch, elevating the medial sole and heel base, and in addition to that, we can go for a hallux valgus split. So long as it's dynamic in nature, it's correctable nature possibly, that can be managed in that way. If the deformity is very much fixed, already it is established, then maybe surgical intervention is required to realign the great toe to add the metatarsophalangeal joint.
Yes, thank you, sir. Dr. Saraswati, she is asking, kindly discuss the role of gait analysis in surgical decision making.
Yes, actually, many centers don't have that facility of gait analysis. Even if we have also, we find difficult time also. But if you don't have gait analysis, look to the observe the gait pattern, especially with respect to foot and ankle. I just want to give a brief example. Like child is walking with a varus foot. So we have two inverters, spastic. It is tibialis anterior, it is tibialis posterior, both causing varus of the foot. So which muscle to be taken for transfer? That will help by your gait analysis by EMG, taking EMG impulses from tibialis anterior, tibialis posterior. You can decide that which muscle, because both are same phase group of muscle, both work in the same phase. In the initial phase, during the heel strike, If the tibial center is working and the tibialis post is working during the toe of stage, foot need to inverted position, and that time the tibialis center is working. So both are the same phase group of muscle. You have to decide which muscle to be taken. So that will be decided by gait analysis by taking EMG point of view. EMG source signals that which muscle is working in which stage. So if the muscle is not working, for example, if when the tibialis posterior should contract, that time the peroneus is working. So foot is going to valgus position, even to the toe position also. That times you'll get that information from the gait analysis. And second part also from observational gait analysis, very important. Look to the status of the forefoot. If the forefoot is going to varus position, it must be a tibial center which is culprit. If the hind foot is going to varus position, it is the tibialis posterior which is going to culprit. So this way, from the gait analysis, you can choose the muscle, which muscle to be transferred, which muscle to be weakened, which muscle to be injected antispastic drug or botulinum toxin. That's how it helps.
Yes, sir. As we would like to add few things, sir. As you said, not all the centers have standardized or 3D instrumented gait analysis, which cost more than 4.5 CR. So, as you said, sir, observational gait analysis is the key. Again, whatever your brain knows, your eye sees. So, more you learn, more you practice this observational gait analysis, meticulously plan, do the good clinical examination, you can definitely plan the correct intervention accordingly. Dr. Nagma has asked, sir, can you please comment on this axis or route for the tendon being transferred?
Sorry, I'm not getting the question.
The question is, can you please comment on the axis or route for tendon being transferred? She want to ask
okay, yeah,
route of the tendon transfer.
Right. The fundamental principle of tendon transfer is fixed. First thing is that there should not be any static deformity. Second thing that the power of the muscle should be grade 5, ideally. But up to 4 can be taken because the muscle transfer loses its power by 1 grade. Okay, third thing, the muscle should have a straight course. That's most important. That probably she is asking that. It must have a straight course of running. It should not go through a round way, so it will kink somewhere. So you have to make a good passage, straight course to the to the insertion side. That's how the action of the muscle will be proper. You should have a straight course.
Yes, rightly said, sir. Absolutely right. Dr. Utkarsh is asking opinion on Botox or phenol block for the local spasticity management. As we all know. Yes.
I think he will tell better than me. You can explain it.
Yes, basically, the phenol is basically neurolysis, chemical neurolysis, and Botox act at presynaptic level. That's we all know this is a common mechanism. So both of them, chemical neurolysis is again they have this more advantages and disadvantage. Nowadays, phenol we are rarely using. We have reduced the use of the phenol at many centers because of its own common complications like local hematoma and other issues. So Botox is a wiser option if the patient can afford.
Right.
Again, sir, Dr. Nageshwar is asking, what should be the ideal outcome of PMR management? Is it sufficient to reach at the situation where our treated patient is improved significantly and walks with SMO and single elbow crutch? That is in spastic diplegic case. Any scope beyond that? I think Dr. Nageshwar need to little bit more. What exactly you want to ask?
It's a very long question.
Yes, sir.
Nageshwar, can you concise your question? The point.
Or you can come on the video call and you can ask.
Anything else?
I think nothing, sir.
So can we then?
Yes, sir. It's almost 8:50 now. So it's one last question. We'll take this. Can you please suggest literature for further reading and learning recommended book?
There is no different book for that. You have to go through the individual conditions. However, for us, like for a physiatrist point of view, simple books. I mean, if you want to CP also, there is one dedicated publication for Kerala chapter of KJPMR, dedicated use of PMR. Very interestingly, everybody has contributed different parts of the cerebral palsy management. Like upper limb cerebral palsy. I have contributed to all upper limb cerebral palsy, lower limb. So everything is there. And books, you can go for orthopedic books like Pazian, Campbell, and Miller's book, or best book. That our book is there also. It is well explained for as far as the requirement of our physiatrist is concerned. This is more than sufficient.
Yes. Thank you, sir. Thank you for this wonderful class. You have given a lot of precious inputs for all of us. By tomorrow evening, I shall be uploading this webinar on our official YouTube channel. Those who have missed, they can share the link. Thank you, sir. Thank you once again. Good night,
Thank
sir.
you. Thank you, everybody, for joining with us. Thank you.
Thank you, sir. Good night, sir. Thank
Good
you.
night.
बोलने के लिए खोला था इतने थैंक यू
अब मोगली चाहिए वो
कौन सी वाली